Welcome to myeyecademy.com. I'm Professor Mahfouz Hussain from Pakistan. Myeyecademy.com is a unique platform for ophthalmic teaching. In this video handbook, chapter 10, section 1, we're going to discuss what's glaucoma and its diagnosis. Let's first discuss the physiology of the aqueous humor. This green structure is iris, and behind the iris is posterior chamber, while in front of the iris is anterior chamber. Aqueous is being produced in the ciliary body, which is red in color here. From the ciliary body, aqueous comes into the posterior chamber, then through the pupil into the anterior chamber. Now remember one thing, 80% of the drainage of the aqueous is through the trabecular meshwork into the venous circulation, while the rest of the 20% of the drainage is through this suprachoroidal space. So from the ciliary body into the suprachoroidal space and into the venous circulation. So 80% through the trabecular meshwork and 20% through the suprachoroidal space into the venous circulation. Now the pathogenesis of glaucomatous damage. There are two theories, ischemic theory and mechanical theory. In the ischemic theory, it postulates that the elevated intraocular pressure reduces blood flow to the optic nerve, which damages the optic nerve in turn. While the direct mechanical damage theory is that chronically raised intraocular pressure destroys the nerve fibers directly and causes mechanical damage, which results in glaucomatous damage. Definition of the glaucoma. It is an optic neuropathy. So it is a type of optic neuropathy which is characterized by high intraocular pressure, disc cupping, and nerve fiber damage. So a triad of high intraocular pressure, disc cupping, and nerve fiber damage. Now how we detect these three things? The intraocular pressure is detected by the tonometry, which we are going to discuss in a minute. Disc cupping you directly see with the ophthalmoscope, direct or indirect, or with the slit lamp, and the nerve fiber damage is detected with the visual fields and OCT of the optic disc. Let's first discuss what is tonometry. Measuring of intraocular pressure is called tonometry. We measure the intraocular pressure with three different methods. One is the indentation method, which is not in practice anymore. Second is the applanation method, in which the cornea is touched with the prisms and we measure the intraocular pressure. Standard is the Goldmann tonometer, which is here in the diagram, which is attached with a slit lamp. Then you can use the Perkins handheld tonometer and tonopen tonometry. The third method is pneumotonometry, in which a puff of air touches the cornea and measures the intraocular pressure. How to do the disc analysis or fundoscopy. Remember, when you're looking at the disc, you look at the two things. One is the disc itself and then the central cup inside. And you have to measure two main things. One is this area between the cup and the disc margin is called neuroretinal rim. So you have to look for the neuroretinal rim, plus you have to look at the cup disc ratio, that the ratio of the cup as compared to the disc itself. Let's see how we measure it. This disc is about 1 millimeter and the cup is 0.9 millimeter. So the cup disc ratio is 0.9. Look at the other disc. The disc is about 1 millimeter and the cup is nearly 0.8 millimeter. So the cup disc ratio is 0.8. So that's how you measure the cup disc ratio. So when you're looking at the disc, look for the cup disc ratio and look for the neuroretinal rim, whether it's intact or not intact, or is thin or not thin. So that's how you basically assess the optic disc head. Next thing you need to do is the angle assessment. The angle between the periphery of the iris and the back of the cornea is called angle. The one method is the depth assessment, that you measure the depth of the anterior chamber and assess what could be the angle. Or the better method is the angle assessment directly, mainly with a gonioscopy. Gonioscopy is a lens which we attach with the cornea, and then you can directly see the angle of the anterior chamber. Look at this diagram. We are doing the gonioscopy. You can see the periphery of the iris and then the pigment in the angle and the trabecular meshwork directly, and you can see that the angle is open. If the angle is closed, you cannot see all these structures. You need to do the assessment whether the angle is open or closed, because that's how you classify open angle glaucomas and closed angle glaucomas. Next is the perimetry. Perimetry and imaging both are done to analyze the nerve fiber damage. Perimetry is actually done with the help of the visual field analyzers. By using the visual field analyzers, you figure out what the patient can see. Now this patient can see a scotoma or a black area in the upper visual field, while the inferior visual field is normal. So this patient has got a superior visual field defect. The next is the imaging. Imaging is done with the help of an instrument called OCT, or optical coherence tomography. OCT can visualize the optic nerve fibers and can detect the earliest fiber damage that cannot be detected clinically. So remember, the nerve fiber damage can be detected in two ways. When you do the visual fields, you actually detect what the patient can see, and by the imaging, you can directly visualize the optic nerve fibers and you can see the damage in the fibers. So let's recap at the end. Glaucoma is an optic neuropathy characterized by high intraocular pressure, which we measure with the help of a tonometer, disc cupping that we see with the ophthalmoscope, and nerve fiber damage, which we see with the visual field analyzers and OCT of the optic disc. Thank you very much for being with me at myeyeacademy.com, and please do give your feedback at the end. Thank you.